Erin, welcome back. It's
All right,
great to
thank
see
you. It's great to be back. Welcome all of you on this frigid morning. It is very good to be here. So, as Judith gave me a great introduction, I always like to say that my appointment, I probably have the most eclectic appointment being in the schools of medicine, but in the departments of family medicine and surgery. But I'm actually a PhD. I'm not an MD, and I do study health workforce issues. Just briefly, what are we going to do this morning? I always like to start with, why do you care? I mean, why did you drag yourself out on a cold morning to come this morning? And then talk about who's in the health workforce. My job this morning is to kick off this forum with giving you a kind of good sense of the waterfront in health workforce. Who's in it? Do we have enough? This is the question people like to ask. I'm going to have you ask a different question this morning. Are they in the right places? Geographies, specialties, et cetera. We're going to talk about education of health professionals, regulation, big issue, and then federal versus state roles. And then, because it's cold, we're going to talk about hot workforce topics. I bet you didn't know there were hot workforce topics. There are, let me tell you. All right, why do you care? People forget that 50%, for example, of a hospital's bottom line are wages. Okay, 50%. That's a lot of money going towards nurses, pharmacists, your orderlies, et cetera. And there's 18 million people in the health workforce. It's 13% of total employment. It's had a 2% annual growth rate compared to slightly less than 1% overall in the economy. And actually, when the economy wasn't doing very well, healthcare employment was still growing. Who's in the health workforce? It's the basic folks you think of, right? It's the physicians and surgeons, it's nurse practitioners, it's PAs, there's the registered nurses and licensed practical nurses, there's the dentists around oral health, pharmacists, optometrists. Those are about 7.5 million workers, okay? But it's not just those folks you've typically heard of. It's also the many, many support staff with whom they work. Look at that. There's 1.4 million nursing assistants out there, and that number is growing rapidly. 806,000 home health aides, medical assistants. Next time you go to your doctor's office, look at who takes your vitals, your BP, weighs you. It's going to be a medical assistant, increasingly. Dental assistants, therapy assistants. And look at that one at the bottom, health information technicians. These are the folks that have traditionally done the coding of records to try to get reimbursement, but increasingly are using electronic health records to get information about patient visits. Psychiatrists, phlebotomists. I always joke, I had no idea we were taking that much blood. But apparently we are, 108,000 phlebotomists in the country. And then so that's about 5 million additional support staff. But one of the things we overlook is that the healthcare workforce increasingly is working with mental health providers and community health workers. So we used to think of the healthcare workforce over here, and then the people in the community over here. But increasingly, and I'm going to talk about this later, as payment models have shifted, and we start rewarding people for keeping people out of the hospital and healthy in their homes, we're doing more around mental health, and we're doing more health education. Look at the number of health educators at 56,000. These are the people who meet with patients to help them understand their medications, help them understand, how to live healthy lifestyles. Look at the community health workers over there, 45,000. What are community health workers? These tend to be people from the community who actually help patients engage with the healthcare system. They may help them understand their medications. They might help get people who are not showing up for mammography, for mammograms, connecting the people in the community, particularly those people who have unmet healthcare needs, actually access healthcare services. And in fact, this was not a group that was actually tracked by the Bureau of Labor Statistics until recently, and they're playing an increasingly important role. So I leave you with the fact that don't think of just your typical healthcare workforce. Increasingly, it includes these other folks. Okay. Am I really sure about those numbers I just showed you? Those are from the Bureau of Labor Statistics. Everyone wants to know how many, insert the blank, nurses, community health workers do we have? It's really, really hard to know. This is a figure from the Health Resources and Services Administration recently put out a report on nurse practitioners. On the far left, you see our licensed nurse practitioners. Those are the people who have the right to practice. They're licensed in their state. They can work as a nurse practitioner. Look, there's about 154,000 of them. The next bar is the nurse practitioner workforce. These are the people who are actually working. They're in the workforce, right? So that reduces the number. And then look, it's only 127,000 who are actually providing patient care. And of those, only 60,000 are working in primary care. Why should you care about this number and what I'm just telling you? When you look at data about the health workforce, you need to ask, are these the people in the workforce? Are they actually actively in practice? Are they providing patient care? Are they in primary care? Are they not? Because numbers are actually really important. So be kind of an educated consumer when you're looking at numbers of whatever type of health professional. Another difficult thing to know is people like to say, we have a shortage. Do we have a shortage? People love the shortage. It grabs headlines. It sells newspapers. What is it? If it bleeds, it leads. For workforce issues, if it's a shortage, it gets published. But experts, there is not agreement in this country about whether we face a physician shortage. So the Association of American Medical Colleges put out a report that said basically we were going to be short 45,400 primary care physicians and about 46,000 by 2020. And then the federal government, HRSA, came out with a report recently that said, in fact, we're going to be short 6,400 primary care physicians. That's with full use of nurse practitioners and physician assistants. But we actually undertook a 2-year modeling exercise. Lots of fun, with good data, brilliant economists, fun folks. Our model shows we don't have a national shortage. We're not going to have a national shortage. You can look at the URL. I encourage you, if you want to play with a really fun interactive tool, go play with our model, because you can play with it for your state and for the nation as a whole. And so our model basically says we're not short overall. The problem is it's a story of haves and have-nots. What are you looking at? You're looking at our map, which is the kind of look at whether we have a shortage or a surplus of physicians for all healthcare services. The brown areas are the folks where there's excess demand for healthcare services. So those areas, and our map actually, you can see, is divided into sub-state regions based on hospital referral regions. So the brown areas are places where we do not have enough physicians to meet demand for healthcare services in 2014. The blue areas are areas of excess supply. Anybody here from Minnesota? Okay. Well, anyway, Rochester, you can see that big blue place up there is Rochester. What's in Rochester? Mayo. Of course, we expect Mayo to be oversupplied. All right, but look at the coasts, quite oversupplied, okay? And look at the middle of the country, it's kind of whitish, okay? So why am I showing you this? You can do this for any type of healthcare service in our model. You can do it for any year out to 2030. Why is this important? In my opinion, national models don't answer the fundamental question of what's it like in your state? What's going on in your area? And you can look at it for specific healthcare services. So for me, if you hear the question, do we have a physician shortage? Do we have a nurse shortage? Do we have a pharmacist shortage? Stop and ask yourself, what area of the country are you talking about? What types of healthcare services are you talking about? Because it may differ very much. We've had really rapid increases in physician in medical school enrollment over time. So this is actually a chart I borrowed from a friend of mine, Cleese Erickson at the AAMC. Top line is showing you the number of medical school enrollments from 2002. The AAMC came out with a recommendation to increase medical school enrollment by 30% by 2015, and they're going to hit that target. You can see the red line is actually the original schools, the original medical schools, their increase in enrollment. So those are the existing schools that increased in enrollment. The blue line are the new schools. So look at that. This is a huge increase in physician enrollment. And in fact, it's actually, when you look at physician enrollment, there's allopathic, MD, and there's osteopathic, DO. So you can become a physician as a DO or an MD. What strikes you about this chart? Really, really rapid growth of DOs. So there's lots of schools opening all over the country, probably in your state, in my state, everywhere, that are opening DO schools. So really, on top of that rapid increase in allopathic, MD, we've had a rapid increase in MDs as well. But everyone likes to talk about physicians. Did you know the nurse workforce is 4 times in size? And in fact, HRSA recently came out with a report, very recently in December, that predicted an oversupply nationally of nurses. Wait a minute. A decade ago, they said we didn't have enough. How did this happen? Well, actually, markets and educators are really responsive. when we come out with estimates of shortage, suddenly people start gearing up production, right? So that line over there on the right is the increase in the number of nurse graduates over time. So what happened? The feds came out, predicted a shortage, bingo. Nursing schools responded, bingo. Now we might have too many. So this is the delicate balance that we get in with projections. But it's not just nurses. Look at that growth in nurse practitioners. This is nurse practitioner graduates. This is from Ed Salzberg at GW, who really looked at this rapid increase. Look at that increase from 2005 to 2013, going from about 7,000 up to 16,000. So it's not just nurses, it's not just physicians, it's nurse practitioners. And guess what? It's physician assistants too. Look at these really rapid increases in numbers of folks graduating from programs. And pharmacists. So this is just to give you a sense. We did, about 10 years ago, people really thought we were going to be in shortages, and the education system rapidly responded and increased enrollment. This is a chart that took me, I kid you not, about 2 hours to pull together for you. Why? I wanted to kind of give you a sense of what's the relationship between, say, the feds come out with an estimate of shortage. And today we say we're going to have a shortage. How long will it take us to respond? So along the x-axis here, you have the length of training. So you have programs that are either high school education or on-the-job training. You have community college, 2-year, baccalaureate, 4-year, postgraduate, and then really postgraduate. And you can see that for medical assistants and nursing assistants, maybe that chart, remember the chart I showed you kind of with the age? Those are the folks you can quickly turn around and educate really fast. So you increase enrollment. Nurses are about 2 to 4 years, depending on whether they're associate or baccalaureate degree. But if you want to change the physician workforce, you need to do it 7 to 12 to 15 years in advance. So you can't just spin on a dime. The flip side is if we find ourselves in oversupply, how do we ratchet back? How quickly can we respond if we've already got people in the pipeline? So think about that when you're thinking about how to change the health workforce. Another really important component, we're moving from education to regulation here, is you need to remember that regulation is a state function. The health workforce is a mix of licensed folks, so there's the licensed group, physicians, nurses, dentists, and then there's the unlicensed folks, medical assistants, home health aides. And licensure, as I said, is a state function. So the state licensure boards set the requirements for entry to practice. So you can have very different requirements in side-by-side states, not only in who is required to be licensed, but once they're licensed, what they can do. Let me show you 2 examples. These are radiologic technologists. What does a radiologic technologist do? They shoot images into your body. They might be mammography, MRI, X-ray, right? These are the folks who are taking diagnostic images for the radiologist to read. You can see the green states are the folks where all different forms of radiography are regulated. So mammography, CMI, CT, MRI. But the orange states, including my own state, nothing's regulated. So in my own state, if you're a hairdresser or a mortician, you have to be licensed. But if you're shooting X-rays into people or doing MRIs, you do not. So you can see there's huge amount of variation that happens, and it's not just RTs. There's other health professions as well. Nurse practitioners are another example I like to use. They're licensed in every state, but what they can do really depends on what state you're in. So the green states are places where nurse practitioners have full practice scope. They can diagnose, they can treat, they can prescribe. The yellow states are sort of in between. They may be able to do one thing or they can't prescribe. The orange states, again, have very restricted practice. So what does this mean? Why should you care? One of the issues, and we can talk about this more later, is that federal regulations can specify what a nurse practitioner can and can't do, for example, for Medicare patients. So some states allow, for example, Medicare won't allow nurse practitioners to order home health, but some states get around it by saying we'll allow it for Medicaid and we'll allow it for third-party payers. So this means if a nurse practitioner has diagnosed a patient, can clearly see that that patient needs home health, and that patient's on Medicaid, they can order it. If that patient's on Medicare, they can. And then there's also really other variation on, whether NPs can order PT and whether they can admit patients to hospitals and sign workers' comp claims and sign death certificates, et cetera. I'm not going to read this slide, but one of the things when you deal with the health workforce you need to realize is there's a difference between licensure and certification. So licensure is, and they sound quite similar. Both are the recognition of competence given to practice to an individual who completes required training, right? So both of those things are true for both licensure and certification. We set a group of standards. We evaluate you against those standards. If you meet them, you're either licensed or certified. But what's the difference? Licensure is actually required to practice. It's mandatory. Certification is voluntary. That means if you're a nurse, in order to hold yourself out as a nurse in practice, you have to be licensed. But as a medical assistant, you can practice as a medical assistant. You can call yourself a medical assistant whether you're certified or not. Why do you care? It's important in terms of what they're held accountable to and who regulates them. But it's also important for me as a geek, because I can't count you as well if you're certified, because you don't have to be certified, right? So trying to get a handle on the number of MAs is hard. If this looks complex, it is. This is from the Institute of Medicine's recent report on graduate medical education. They had this wonderful figure which talked about the various first of all, let me explain what it is. It's the pipeline of how physicians become educated and regulated out to practice. So there's pre-medical, they go to 4 years of medical school, they do residency and fellowship, and then they get out into medical practice. All of these boxes are the various regulatory, credentialing, and certifying agencies that affect physicians along their pathway. That's a lot of folks. It's very complex. The other thing is really important to note. There's lots of regulation when they're being educated and certified. There's less regulation once they're out in practice. So once you become licensed as a physician, recently we're looking at maintenance of certification where you actually have to demonstrate competence, but for a while you could become licensed as a physician, and once you were licensed, you're competent, right? You're competent. You got a license. So we're increasingly working on trying to figure out how to regulate that tail end. But I wanted to show you this figure just to show you how complex it is. So if it is so complex and you can't move, the result is if you try to get all these partners on the table, we end up lurching from oversupply to shortage. Because typically in this country, we don't plan ahead. Workforce planning, that's for sissies. No, we wait until we're at the bottom of the curve, and then we all gear up independently. Every nursing school starts pouring nursing enrollments in. And then we all end up at the top of the heap, and then everyone says, oh, we're in oversupply. And then we go. So we don't do a whole lot of workforce planning, and that's a problem in this state, in this country. So if we wanted to smooth that maybe we like to lurch, but for those of us who maybe wanted to be a little less lurchy and smooth that cycle, what could we do? The federal role really is to invest in better data, and so the Health Resources and Services Administration is working on that and developing workforce projections. State is also doing that, and I think it's really important for states to be engaged in this. I get so frustrated. I was just saying to Mark, I get so frustrated at these national workforce models because so much of what happens is at the state level. And so you need your own state data. You need better sense of what's happening in your area because it's going to look different. Idaho looks different than New York, and we need to understand that. And Florida looks very different than Minnesota. So we need better data at both the state and federal level. But folks, we need some strategy. We have very little workforce planning strategy in this country. We had, the ACA created the National Health Workforce Commission, but it was unfunded. And that was supposed to be kind of our Uber strategy group. They remain unfunded. States are desperate for strategy, so they're going to the National Governors Association, and they're actually seeking advice from us and from others in the Health Workforce Technical Assistance Center. But states they're struggling right now to plan their workforce. Big education challenges. One of the things that I find most frustrating is that we invest in education without ever asking, what return are we getting for that? Do we need more nurses? Do we need more pharmacists? Maybe we need them in different places. So we really need to be using the data to drive our investment decisions. And then we need to ask, what's the return on investment? Are those nurses, are those pharmacists, are those dentists actually practicing in underserved areas? Are they serving underserved communities? So in our own state, we're looking at, for example, tracking the dollars that we spend on Medicaid and whether we're getting a return on those investments. And finally, money. Money leads. So, when I look at the federal levels, I'm quite entranced, and I'll show you in my later presentation, by all these efforts going on in CMS and CMMI to really shape new models of care. And at the state level, really, we need to be kind of using strategically our Medicaid dollars. So think about how can you use those Medicaid investments to shape the workforce. So I'm going to leave you with what I see as the burning health workforce issues. why, and people ask me this all the time, Erin, why can't you just get the numbers right? I mean, how hard could it be? Really? So I hope you have a little sympathy for my job. First of all, figuring out how many of whatever we have is a challenge. But then the other point of projections, keep in mind that if you put out a projection, by definition, if education systems then rev up, it's going to be wrong, right? Because you put out a projection and you say we're going to have a shortage of X, and then all these programs kind of start doing stuff, and then suddenly you increase the pipeline and your projection of a shortage is suddenly an oversupply. But the biggest problem we're having in modeling is trying to figure out what new models of care are going to mean for our model. So what does it mean when we start using more nurse practitioners and physician assistants and nurses in new roles? And I'll talk about that later. Burning on Medicare funding of GME. Lots of questions. We're spending, Mark will correct my numbers, but approximately $13 billion on Medicare GME. What do we get for it? Who's tracking it? And about $3.5 billion in Medicaid. What are we getting for it? This is a big issue in this country. Scope of practice. Anybody a hockey fan here? If you love hockey and you like hockey fights, you know what's even better than hockey fights is scope of practice battles at the legislature. So if you like scope of practice battles, go watch the chiropractors fight with the family docs and the nurse practitioners. And this is serious stuff, folks. And I make a joke, but I'm worried about it. If we ask, what does the patient need instead of what the profession needs, I think we might look at scope of practice a little different. And then I'm really interested, and I'm going to talk to you later after the other speakers about new models of care. So that's and kind of the workforce implications of that. So that's your overview of the frozen waterfront. If you have questions, my contact information is at the end. Thanks very much.
That was great.